So the patient we're talking about today is a 55-year-old African-American woman, and she presented to her physician feeling a little tired and complaining of some bone pain and back pain. And so she was evaluated and was noted to be a little bit anemic. Her kidney function was fine, her calcium was normal. But when they did look at her MRI, they found some lesions that were suggestive of a malignancy. So in order to confirm a diagnosis of multiple myeloma, she underwent a bone marrow biopsy, and the bone marrow biopsy showed plasma cells consistent with the cancer. And these cells contain the 414 translocation. So given her beta-2 microglobulin of 5.0, she was felt to have stage 2 disease using the revised ISS staging system. So based on that, she was started on treatment with bortezomib, lenalidomide, and dexamethasone, the so-called VRD therapy. And she received 6 months of that and tolerated it well and achieved a very good partial response, not quite in remission. She did speak with her physician at the time about potentially doing a stem cell transplant, and that was discussed. And she decided not to go ahead with a high-dose chemotherapy, and instead just was maintained on lenalidomide and dexamethasone for as long as her disease stayed controlled. When thinking about her case, she's young. She's 55 years old. Certainly, I would consider that young. And so, and she has some high-risk features. The 414 translocation tends to predict a more aggressive form of the disease with more rapid relapses. She was, I think, appropriately treated initially with the bortezomib, lenalidomide, dexamethasone regimen and seemed to tolerate it well and got to a very good partial response, but I probably would have tried hard to convince her to undergo a high-dose chemotherapy with a stem cell transplant because, it's been shown to improve survival, and when you're 55 years old, her main risk of dying is going to be from the multiple myeloma, not some complication or something like that.